Thank you very much, Joe. It's a pleasure to be here. In the last 10, 15 years has seen a dramatic increase in our understanding of the neuropharmacology of addiction. There's been a lot of very dramatic findings that have shown at the cellular level, at the neurochemical level, what happens when one becomes addicted to drugs. So you can see in a test tube, you can see in just a slice of brain tissue phenomena such as drug tolerance, that is, the decreasing effect over repeated administrations of a drug. You can see drug withdrawal symptoms, that is, if the cells have been bathed in a drug for some period of time, if drug use is suddenly terminated, you can see withdrawal symptoms occurring at the cellular level. So these really are very, very dramatic findings. But these molecular studies of drug addiction are lacking in that they don't address a very important phenomenon of addiction that you can only see if you look at the whole organism rather than just a slice of the brain. And these are the effects of drug anticipation or drug expectation on phenomena such as drug tolerance and drug withdrawal symptoms. And we see these with virtually all addictive drugs. I'm going to just illustrate the kind of finding with two drugs of abuse used by humans, alcohol and caffeine. If you look at, this is an experiment that was done a few years ago in Great Britain. The subjects were college students, and some of them drank a measured amount of alcohol in a common beverage, beer. So it was a beer-flavored beverage with a known amount of alcohol added to it. The others drank the same amount of alcohol over the same period of time, but in a novel beverage, a blue peppermint-flavored beverage that is not typically associated with alcohol. And after consuming the alcohol, they evaluated how intoxicated these students were with paper and pencil tests, with motor coordination tests such as the pursuit rotor task, where they have to keep a stylus on a moving disc for some period of time, and other tests of intoxication. How they got a page with many letters on it, and they had to circle words from that letters that form words from left to right, vertically or diagonally. So how they performed on this test of cognitive ability. And what was found is that if they drank the alcohol in the usual alcohol environment, that is in the context of beer, the alcohol didn't have too much of an effect on them. That is, they were very tolerant to alcohol. Those who drank the same amount of alcohol over the same period of time, but in the context of the novel cue, the blue peppermint flavored beverage, were very intoxicated. So the effect, if you get alcohol where you expect it, it has a smaller effect than if you get alcohol where you don't expect it. And the same is also seen with the effects of caffeine on blood pressure. In a study that was done in Switzerland a few years ago, experienced coffee drinkers got a measured amount of caffeine. Some of them got it in a coffee-flavored beverage, an espresso. Others got the same amount of alcohol, but via intravenous infusion. That is, the blood levels of alcohol in those that drank the alcohol were monitored as they consumed, the caffeine rather. The blood levels of caffeine were monitored as they drank the coffee-flavored beverage. And the same amount of caffeine was infused intravenously over the same period of time. And in fact, these same individuals at a different time when they participated in the second half of the experiment. And what was found was that the alcohol had a much larger effect when it was presented in the absence of stimuli that had signaled the caffeine in the past. That is, the caffeine had a large effect on blood pressure when it was intravenously infused, but if you consume the same amount of caffeine over the same period of time, but you expect the caffeine because you get it in the context of the taste cue, the odor cue, the thermic cue, and so on that had signaled the caffeine in the past, it's been known, it has a smaller effect. You're tolerant to caffeine. So you can't see this in the brain slice. You can only see this in the whole organism. That is, the effect of a drug is smaller if the drug is expected than if the drug is not expected. Well, we had studied this for a very long time, the effect of drug expectation on drug tolerance, and had published many papers about it. And so I was very surprised when somebody brought to my attention the work of this individual, Wilkie Collins. Wilkie Collins, a Victorian novelist, a colleague, indeed a close friend of Charles Dickens, wrote many novels. Perhaps the most famous of his novel is The Moonstone. It was published as a book first in 1869. That picture of Collins was taken in 1868, so just about the time The Moonstone was published. And in The Moonstone, Wilkie Collins not only knew about the phenomenon of drug tolerance, but he also knew how it was modulated by the expectation of the drug. This, of course, is a work of fiction. And in The Moonstone, without going into the plot details in any great detail, but this does contain a spoiler. A young man, Franklin Blake, agrees to take laudanum, that is tincture of opium dissolved in alcohol, on 2 occasions. Once it was surreptitiously administered to him as a prank. The second time, he agrees to take it as part of an experiment. And the experimenter for this experiment is somebody by the name of Ezra Jennings. So Ezra Jennings agrees to administer opium to Franklin Blake, having known that he had taken the drug once before, and therefore tolerance will be an issue. And this is what it says in The Moonstone. I said it was published in 1869. In fact, it was published in 1868. I shall run the risk of enlarging the dose to 40 minims. 40 minims is about 25 milligrams of morphine, the equivalent of it. On this occasion, Mr. Blake knows beforehand that he is going to take the laudanum, which is equivalent, physiologically speaking, to his having, unconsciously to himself, a certain capacity in him to resist the effect of the drug. Well, Wilkie Collins's knowledge of tolerance is exactly what I'm going to talk about today. That is, if you know the drug is coming, you have within you a certain capacity to resist the effect of the drug. Indeed, tolerance is due partly to knowing beforehand that you're going to get the drug. And this tolerance produces an ability to resist the effect of the drug. That is, we respond in anticipation of a drug with responses that attenuate the effect of the drug. Now, the study of anticipatory responding is, in fact, the study of Pavlovian conditioning. Ivan Pavlov won the, far left switch. Okay, thank you. So Ivan Pavlov won the Nobel Prize for Physiology in 1904. And up until that time, he's now in his early 50s, he never did any work for which we know him for today. So he reoriented his research based on observations that he made during his digestive physiology research, which didn't form the basis of his Nobel Prize, but did consume him for the last third of his scientific career. And he essentially accidentally discovered conditional responses during the course of his digestive physiological research. So what is Pavlovian conditioning? Well, in Pavlovian conditioning, a stimulus called a conditional stimulus is paired with another stimulus called the unconditional stimulus. The unconditional stimulus has that name because it unconditionally elicits some response. It doesn't take any training. The organism is born with a reflex, and the unconditional stimulus is the stimulus that initiates the reflex activity. So in much of Pavlov's work, the unconditional stimulus was stimulation of receptors in the mouth by food or by a very dilute acid. And what this this type of stimulation is carried by afferent nerves to the central nervous system, and the central nervous system elicits efferent activity, which in this case is salivation. So these stimuli unconditionally elicit an unconditional response of salivation. And what you do is you take some stimulus called a conditional stimulus, which is arbitrary. It's selected merely because it does not elicit that particular unconditional response. Salivation in this case. In much of Pavlov's work, he used a tone, for example. So you pair a tone with stimulation of receptors in the mouth, and after some number of pairings, the tone comes to elicit salivation in this example. So the tone elicits the same response as did the unconditional stimulus. And, as Pavlov said, the activity of the salivary glands has thus been called into play by impulses of sound, a stimulus quite alien to food. So you can get a stimulus that doesn't elicit a reflex, but conditional on pairing with the unconditional stimulus, it does elicit the reflex, hence the name conditional stimulus and conditional response. Well, drug administration corresponds to this type of Pavlovian conditioning. If there is stimulation of receptors by a drug as the unconditional stimulus, this stimulation travels to the central nervous system, and the central nervous system elicits some response, usually a homeostatic response that attenuates the effect of that insult. If the effect of stimulation of receptors is to lower body temperature, for example, the homeostatic response to that is to change blood vessel diameter, to change blood flow ratios between the interior viscera and the external skin, and what you get is a response that attenuates the depression in body temperature caused by the drug. But a drug is not elicited administered in isolation. If you administer a drug, there are always stimuli that tend to be uniquely present at the time of drug administration. You can't somehow foist, unless you take special precautions, you can't foist the drug on an organism. The organism typically knows it's going to get the drug because there's the sight of a hypodermic needle if the drug is to be injected, or there's the taste of coffee if the caffeine is to be administered. So there are typically cues present at the time of drug administration. And these cues come to elicit the same type of drug compensatory conditional response that's elicited by the drug. So in response to cues that signal a drug, you make responses that attenuate the effect of a drug. So how might this work? These are not real data, but these are idealized data of the sort that many people have demonstrated now in many laboratories with many species. If you administer alcohol, it could be ingested alcohol, it could be injected alcohol, and what you look at is body temperature over time. In a room that's maintained at normal room temperature, alcohol has a hypothermic effect. That is, it decreases body temperature. And you can see, following the administration of alcohol, body temperature decreasing and then gradually returning to normal. If you administer alcohol on a number of occasions, and then go through your whole alcohol administration ritual, but don't administer alcohol, administer a substance that should have no effect on body temperature, like physiological saline, what you see is an increase in body temperature. This substance will cause an increase in body temperature if and only if it's administered to somebody that had previously paired these stimuli with a drug that decreased body temperature. So here's why Pavlovian conditioning contributes to tolerance. It's because if you administer the drug over and over again, there's a conditional response of increasing strength that's attenuating the effect of the drug. So if you're confronted with cues that have signaled the drug, you make a response that attenuates the effect of the drug. The association between these cues and the drug effect gets stronger over repeated administrations, so the effect of the drug becomes increasingly attenuated. So here are idealized data of the first, fourth, seventh, and 10th time the drug is administered, and you can see tolerance is developing to the drug. Now, there are many reasons why tolerance develops. That is, the effect of the drug is getting smaller. It's having a smaller hypothermic effect over repeated administrations. but one major reason is because you are responding in anticipation of the drug. You're responding to all these cues that have signaled the drug by a response opposite to the effect of the drug, and this drug opposite response is increasingly canceling the effect of the drug. I think we've all had some examples about how stimuli that have signaled the drug effect might cause responses that are opposite in direction to the, because they're, as I said, it's impossible to administer a drug without stimuli that have signaled the drug in the past. So there are all these cues that are present. The particular cue depends on the drug, that tend to only be present when the drug is administered. So you don't get caffeine in your signal in your system without knowing that caffeine is soon going to arrive in your system, unless you're in a laboratory and it's intravenously administered. And as I say, I think we've all had some experience with that. The experiment hasn't been done, but I think decaffeinated coffee and experienced coffee drinkers would have a soporific effect. It would make you sleepy, because what happens is your body gets ready for the insult of this drug that has an alerting effect, and what you do in anticipation of that is to make a response that it is opposite in direction to it. And if you get all the cues for caffeine without actually getting the caffeine, you get sleepy. There's lots of evidence for this view of drug tolerance, and I'm going to present you with virtually none of it. I'm just going to just kind of describe the designs of experiments that are done and not present you with the data. But the one general type of design demonstrates the environmental specificity of tolerance. If a drug is administered over and over again in a particular environment, he is schematically illustrated by a green box. So the drug is administered on, say, once a day in a particular environment, in this case, a green box. And then on a final test, you get that same dose of the drug, but either in the usual drug-associated environment or in a different environment. What you find is that you're tolerant, you or any other species that's been studied, you're tolerant to the drug if you get it in the context of cues that have signaled the drug in the past, that is, the drug has a small effect, or you're not tolerant to the drug if you get it in the context of cues that have not signaled the drug in the past. So if you get caffeine in the context of coffee, you're tolerant. If you get caffeine not in the context of coffee, you are not tolerant to it. There are many, many demonstrations of environmental specificity of tolerance with many species, many drugs, and many drug effects. I would certainly say hundreds of demonstrations. The most dramatic demonstrations are demonstrations of tolerance to the lethal effects of drugs. So heroin, for example, causes respiratory depression. Now, tolerance develops to this in the heroin addict. The individual that takes heroin very often doesn't show much of a respiratory depressive effect of the drug. But what about if that individual with a history of heroin administration gets the drug in the context of cues that have not signaled the drug in the past? Then a drug that might have a very small effect would have a large effect, and in fact might lead to fatal respiratory depression. And this is in fact been demonstrated. That's okay. You'll have to take my word for it. This is a PC to Mac error. So you can forget about the slide. The fact is that if a rat gets a particular drug over and over again in a particular environment, such as heroin or alcohol or pentobarbital or barbiturate, and gets very tolerant to the drug, if they are given the same dose of the drug or a somewhat higher dose of the drug, but now in the context of cues that haven't signaled the drug in the past, they are more likely to die than if they get the drug in the context of cues that have signaled the drug in the past. So there are also now probably a dozen clinical and epidemiological reports from humans that have indicating that environmental cues contribute to heroin overdose. That is, the human that gets the heroin in an environment not previously paired with the drug is more likely to suffer an overdose. Well, you can't do an experiment with humans, but you can do clinical studies. If the individual who suffers an overdose gets medical attention quickly enough, they will survive the overdose, because you can give a type of drug called an opiate antagonist that immediately displaces the opiate from the opiate molecule from the opiate receptor. And it's quite dramatic. They immediately, get off the gurney and walk away if they get an opiate antagonist in time. So what you can do is question heroin overdose survivors about the circumstances of the drug administration on the occasion of the overdose compared to the circumstances of drug administration when they didn't suffer an overdose. And they show that environmental cues, that is, if you get the drug where you expect it, you tend to not be at risk for overdose. But if you get the drug where you don't expect it, you are at risk for overdose. You can also do epidemiological studies. So you take a large number of heroin overdose victims who have been revived at the hospital. And you also get a number of people admitted to the hospital at about the same period of time in this large inner city hospital, who were admitted for reasons having nothing to do with heroin overdose. They suffered an automobile accident or any other type of accident. But blood work indicates that they took heroin within an hour prior to their admission. So they took heroin before they were admitted to the hospital, about the same amount of heroin as the individuals who suffered an overdose, but they were admitted for just coincidentally for other reasons. And you can see the circumstances of drug administration for the people who suffered an overdose versus the circumstances of drug administration for the people who took about the same amount of heroin and didn't suffer an overdose. And again, this type of epidemiological studies indicate that taking heroin in an environment not previously paired with the drug is a risk factor for overdose. Well, I have more recently bemoaned the fact that this is not generally known. That is, the role of environmental cues in heroin overdose, which is a major public health problem. About 1% of heroin addicts each year succumb to so-called overdose. And in fact, what is it that causes heroin overdose? The usual view has been that it's simply too much heroin. But as way back in 1972, Edward Brecker wrote a book called Licit and Illicit Drugs, in which he said that he evaluated the literature. This is a long time ago, 1972, indicating that the deaths cannot be due to overdose. There never has been any evidence that they're due to overdose. And there has long been a plethora of evidence demonstrating that they are not due to overdose. And in fact, this is all old quotes. Cherubin, a well-known physiologist, after examining heroin overdose victims, said so-called overdose is an idiosyncratic reaction to an intravenous injection of unspecified materials and probably not a true pharmacological overdose of narcotics, 1972. So what happens is if they simply don't have enough heroin in the system to kill them. And sometimes a group of individuals will administer from a common drug supply, all administering about the same dose of the drug, and one and only one will suffer an overdose. Green, the term overdose is served to indicate lack of understanding of the true mechanism of deaths and fatalities directly related to opiate use. We're up to 1977 now. One must conclude that in the great majority of cases, death was not the result of the toxic quantity of morphine in the blood. When heroin goes through the liver, it's converted to morphine. So you examine how much heroin they evaluated by examining morphine levels in the blood. and Zador, Dark and Zador, they're in Sydney, Australia. Continued utilization of the term overdose to cover all heroin-related fatalities may be counterproductive in developing strategies to reduce the morbidity and mortality associated with heroin. And Deborah Zador more recently wrote a paper in which she bemoaned the fact that people still call it an overdose. And she talked about how all this research that had accumulated indicates that heroin overdose is not an overdose as we usually think of a drug overdose. It's something else. And she suggests that perhaps we ought to pay a lot of attention to the role of drug-associated environmental cues in drug overdose. Well, again, I was surprised to see that perhaps we had been preempted in, I don't know how many of you read M.C. Beaton. She a very productive novelist who writes a lot of easy-to-read mysteries. One is the Agatha Raisin mystery series, and in the Hamish Macbeth series, she probably has 20 books now. And her real name is Marion Chesney. And M.C. Beaton, one of the Hamish Macbeth books, is Death of an Addict. Hamish Macbeth, she wrote this in 1999. Hamish Macbeth is an unambitious constable in the Highlands of Scotland who keeps on having these insights and is afraid he'll be promoted out of the Highlands that he loves to a more urban area. And in any event, in Death of an Addict, which in fact was on television, it was the Hamish Macbeth series is also on BBC television. There's one scene where Macbeth is talking to the pathologist on the scene of an apparent heroin overdose in the Highland. The pathologist's name is Dr. Sinclair. Hamish Macbeth is played by Robert Carlyle in the BBC television series. Dr. Sinclair leaned his, well, you can read it. Dr. Sinclair said the reason for tolerance to heroin is partially conditioned by the environment where the drug is normally administered. If the drug is administered in a new setting, much of the conditioned tolerance will disappear and the addict will be more likely to overdose. Well, I was shocked to see that in this work of fiction set in a remote area in the Scottish Highlands. So, and especially when a lot of people in the business don't appreciate the role of environmental cues in overdose. So in fact, I wrote to Marion Chesney and said what was the basis for this insight that she had. And she said she just can't remember where she got the information from. She just can't remember. Okay, well, there's other evidence other than environmental specificity of tolerance that learning contributes to tolerance. And I'll just, it would be too long to describe all the experiments that have been done, so I'll just describe one experiment to give you a flavor of the type of experiments that have been done. This phenomenon is called extinction of tolerance. Imagine a drug during the first phase of the experiment, the tolerance development phase, is administered over and over, here once a day for 5 days. M means morphine. So morphine is administered once a day for 5 days to 2 groups. And sometime later, say 5 days later or 6 days later, everybody gets their 6th injection of morphine during a tolerance test. The only difference is the extinction group gets repeated injections of saline during that period between tolerance development and tolerance testing. That is, they are confronted with drug-associated cues without getting the drug. What this does, by presenting a conditional stimulus without the unconditional stimulus, you get a phenomenon called extinction. The conditional response decreases in strength. So they go through the entire drug administration ritual without getting the drug. And every one of those saline administrations should constitute an extinction trial because they think they're going to get morphine, but they don't. It's like getting decaffeinated coffee and over again. Eventually, coffee will no longer lead to a caffeine compensatory conditional response. What's of interest is the response to morphine on the final tolerance test. Is it a big response or is it a small response? If tolerance is partially attributable to learning, you would expect a small response in the control group. That is, they should be very tolerant to morphine. and a big response in the extinction group, because the conditional response that mediates tolerance, that's responsible for tolerance, is decreased as a result of extinction. So two groups have exactly the same pharmacological history. They get the same doses of morphine equally as often and at the same intervals. However, the seemingly innocuous administration, the seemingly innocuous operation of administering a neutral substance over and over again should reverse tolerance. And what sort of results are found? Well, here I've made the size of the M indicate the magnitude of the response to morphine. So during the tolerance development phase, they initially have a large response to morphine, and then it decreases in size over repeated administrations of the drug. And when you give the final tolerance test, they're very different in the response to morphine. The 6th administration of morphine has a large response in the extinction group and a small response in the other group. Well, I've talked about tolerance. What about withdrawal symptoms? A very important phenomenon seen with drugs of abuse are so-called withdrawal symptoms when drug use is terminated. Well, an important contributor and by the way, tolerance and withdrawal symptoms are very highly correlated. You don't have one without the other. That is, if you haven't administered drugs often enough for tolerance to be pronounced, you don't see withdrawal symptoms when you no longer have access to the drug. On the other hand, if tolerance is very pronounced, if the response to the drug is very small, then termination of drug use causes pronounced withdrawal symptoms. And withdrawal symptoms are the same conditional response that mediates tolerance, the same drug compensatory conditional response that mediates tolerance. So imagine a heroin addict that is confronted with cues that normally signal the drug and then gets the drug, has a small response to the drug because these cues elicit the conditional response that mediate tolerance. On the other hand, if they're confronted with cues that signal the drug but you don't get the drug, you're left with these drug compensatory conditional response that now have nothing to attenuate. There is no drug effect for them to cancel. So they're simply conditional responses. And these are what are called withdrawal symptoms. They're really preparations for the next drug administration. They're not the toxic effects of all the prior drug administrations. So if you get the cues for the drug without actually getting the drug, the response that can save your life, that is the conditional response that might mediate tolerance to the lethal effect of the drug, actually is also the response that are going to be displayed as withdrawal symptoms if access to the drug is denied. So drug withdrawal symptoms are the price you pay for tolerance to the drug. It is exactly the same mechanism. The cigarette smoker doesn't smoke cigarettes in isolation. There are cues that are present at the time they smoke cigarettes. Well, suppose that individual now wants to stop smoking cigarettes. They're still confronted with cues that have signaled cigarettes in the past, advertisements for cigarettes, other people smoking cigarettes, the smell of cigarettes, and the responses that they've learned to make in the presence of these cues that were responsible for tolerance to this very lethal drug, nicotine, now are expressed as withdrawal symptoms. So, as we've said, it's the anticipation of the drug rather than the drug itself that is responsible for these symptoms. Some drug withdrawal symptoms are more accurately drug preparation symptoms. Again, this has been known for a very long time. In the United States, the first serious anti-drug legislation was the Harrison Narcotic Act that became effective in 1915, which essentially denied everybody access to certain drugs, like opiate drugs, like morphine. And the government, being very humane, set up clinics to treat these addicts. The big clinics in the United States were in Lexington, Kentucky, and in San Antonio, Texas. The first superintendent of the first addiction treatment facility in the United States was somebody by the name of Lawrence Kolb. And it was thought that there would be no problem, That is, yes, these individuals might suffer some withdrawal symptoms, but it was thought that these withdrawal symptoms were due to the effects of all the drugs that they had taken up to the time of enforced abstinence, and now they would no longer have access to these drugs. They might be uncomfortable for a week or two, but then they'd be as good as new when they no longer displayed withdrawal symptoms. So what Lawrence Kolb noted, this is 1927, that nearly all those who abstained from in the clinic now, who abstained from narcotics, reported that they had no desire for the drugs unless they see somebody else take them, or unless they associate with other addicts in situations which they formerly enjoyed. So being confronted with stimuli that have signaled the drug in the past are what elicits craving and withdrawal symptoms. Again, quoting Kolb, he gave a more familiar example, the tobacco smoker, a cured smoker, who usually does not crave tobacco, may feel an intense desire resembling hunger when he gazes on a box of cigars or sits in the company of friends who are smoking. The genesis of this desire is apparently wholly mental. Indeed, it's all a Pavlovian conditional response. All of these stimuli have been paired with the systemic effects of nicotine in the past, and so they make a conditional response that attenuates the effect of nicotine. There's also many experiments with animals and humans now that have clearly demonstrated that environmental cues elicit withdrawal symptoms. Well, what's the more recent research in the area of the role of learning in drug tolerance and drug addiction? They concern internal cues. Everything that I've said so far is so-called exteroceptive cues. They're external and public, apparent to the individual taking the drug and the experimenter studying the drug effect. So you can have visual, auditory, or olfactory cues present at the time of drug administration, and everybody can see them. So if you present caffeine in a coffee-flavored beverage, that's an external cue, the sight of the coffee, the smell of the coffee. But also, the individual drug taker has certain internal cues, certain cues that are only accessible to that individual. They're internal and private. So the individual might take a drug only when they're anxious. So anxiety is a cue that's paired with drug administration, but it's not a cue that's obvious to anybody except the individual taking the drug. We have been interested in two types of interoceptive cues. There are certainly others, but we've been interested in only two types of interoceptive cues so far. One is self-administration cues, and the other is pharmacological cues. Self-administration cues are those cues involved in administering the drug to yourself. Most drugs of abuse are not administered by the experimenter in the real world. They're administered by the individual taking the drug. You have to make a decision to take the drug. You have to get up and prepare the drug. And I don't know what these cues are, but they're internal cues that have to do with the self-administration process. And this phenomenon has been primarily studied by a former graduate student of mine, Laurie Weiss Kelly. The other type of internal cue that we have studied are pharmacological cues. If you administer a drug, you don't experience the peak effect of the drug without experience some earlier effect of the drug. So the individual self-administering heroin, for example, might immediately feel a little bit different or might suffer some perceptual effects before they get the peak rush of the drug effect. The early effect of the drug can serve as a cue for the later, larger effect of the drug because of the dynamics of the time effect curve of the drug. And this has been studied primarily by Joe Kim and Marta Sokolowska, both former students of mine. What about self-administration of tolerance? There's now been a lot of experiments, and the general finding is that self-administered drugs have a smaller effect than passively received drugs. So if you administer a drug, how might somebody do this? Somebody might do it as somebody did a long time ago, before there were more stringent ethical constraints on how you can use humans in research. Somebody did this, in fact, at McLean Hospital, part of Harvard University. The participants were a bunch of alcoholics for inpatient treatment. And during the first phase of the experiment, They could drink whenever they wanted. They sat down at the table, they had a bottle of bourbon in front of them and a glass. They could pour it and drink it however much they wanted. And you saw how intoxicated they got after some period of time. And they didn't get very intoxicated. They were very tolerant to the drug. In a subsequent phase of the experiment, which was some weeks later, these same individuals got the same bourbon in the glass, but they couldn't drink whenever they wanted. They had to drink in an instructed manner, and the protocol of instructed drinking was approximately the same as a self-administered drinking. So they drank about the same amount over the same period of time, and they got far more intoxicated when they didn't self-administer the drug. Laurie Weiss-Kelly indicated the same phenomenon in rats, where one group of rats can self-administer ethanol, that's self-administering ethanol. Another group of rats is yolked ethanol. Every time that self-administering rat chooses to sip some ethanol solution, the yolked ethanol animal got the same amount of ethanol administered directly into its stomach. The self-administering ethanol had the same type of surgery, but didn't get the ethanol administered into its stomach. It got it through by drinking it, consuming it. So this one self-administered the ethanol. The yolk partner didn't self-administer the ethanol, and it was also a yolked water group. And what Laurie found was that the self-administering ethanol rat was very tolerant to the drug, and the yolked ethanol rat was very intolerant to the drug, showed a lot of intoxication. Now remember, withdrawal symptoms are the conditional response that mediates tolerance. Therefore, we would expect that the self-administering animals, if they are presented with the self-administration cues, that is, if they could go through the self-administration ritual but don't actually get the drug, they should show more withdrawal symptoms, and that's certainly done. That's certainly been demonstrated. Withdrawal symptoms are greater following a history of drug self-administration than following a history of passively received drugs. The other type of internal cue that I talked about was drug onset cues, and we've called this an intra-administration association, where the early effect of the drug serves as a conditional stimulus, and the later larger effect of the drug serves as an unconditional stimulus. So if this is a time effect curve of the drug, then the early effect of the drug, when it's detected, should cause a conditional response. Joe Kim has done several elegant experiments demonstrating that intra-administration associations contribute to drug tolerance. This is the design of one such experiment. Imagine during the so-called training phase, or the tolerance development phase, I'm sorry, I turned it off. During the tolerance development phase, the drug is infused intravenously each time over a long period of time. Suppose that's 5 milligrams of morphine infused over a long period of time. And that happens once a day for a number of days. On a test, you give the early effect of the drug. You give just a small dose of the drug infused over 1/10 of that period of time. That's mimicking the drug onset cues. In the past, that stimulus has been paired with a later larger drug effects, but on the test it's not. And what you find is a compensatory conditional response when that happens. So a small drug effect actually produces an effect opposite that of the drug if the organism has a history in which a small drug effect signaled a later larger drug effect. It's also interesting that intra-administration associations of this sort are very important with respect to drug tolerance. You probably can't read that. That's a U.S. Food and Drug Administration warning label. You don't have to read it. But it's on a analgesic called fentanyl. And fentanyl is often administered by a patch that's placed on the skin. It's a very potent opioid analgesic. It's a synthetic opioid. It's made in a laboratory or a chemical factory rather than taken from the opium poppy, but it's thousands of times more potent than morphine. So you use very little of it. And a convenient way to administer it is on a patch. And there's a warning concerning fentanyl transdermal patch. Because what they found is that a lot of people were suffering overdoses, some lethal. And it wouldn't be, although most of them were in a clinical setting when they had the patch so they could be revived. You wouldn't expect this patch to cause an overdose because the patch is so potent, it's not used as the first analgesic that's given to an individual suffering from intractable pain. They've had other opiates through oral administration, morphine, for example, and they should be very tolerant to opiates. And what happens is they're not tolerant to opiates. They are tolerant, but when they switch from the one route of administration to another, in other words, they change the drug onset cues, they suffer an overdose of fentanyl. And in fact, Joe Kim and I wrote an interesting paper about how these cases of fentanyl overdose could be explained by changing as a result of changing the drug onset cues. Drug onset cues also, since they elicit withdrawal symptoms, might be very important in the withdrawal symptoms seen when given a small dose of the drug. And what we have here is one of the tenets of Alcoholics Anonymous. Once he takes any alcohol into his system, something happens both in the bodily and mental sense, which makes it virtually impossible for him to stop. The experience of the alcohol will confirm that we are without defense against the first drink. Well, why can't the alcoholic take the first drink without relapsing to alcohol? One reason, as several people have suggested, might be because that small taste of alcohol in the past has been followed by a larger dose of alcohol, and the drug onset cue elicits the response that would attenuate the effect of the much larger dose of the alcohol. But if you don't get the larger dose of the alcohol, you're left with this drug compensatory conditional response, which are withdrawal symptoms. Well, in conclusion, everybody in the drug addiction complex can agree on one thing. Whether you're an addict, whether you're a researcher, whether you're a clinician, everybody agrees that relapse is the problem in the treatment of drug addiction. It's not difficult to get somebody to stop using drugs for a while, but what's difficult is to get them to have long-term abstinence. Everybody who's tried to stop smoke cigarettes can confirm that. Every heroin addict has gone through periods of withdrawal in which they thought they were finished with the drug. They no longer crave the drug. But in various studies, 70 to 90% of them will relapse to drug use. So again, to quote a researcher, W.C. Fields, don't say you can't swear off drinking. It's easy. I've done it 1,000 times. Why is relapse the problem? Well, it seems like the former addict is bedeviled by some remnant of the prior drug experience, and many literate addicts use the same analogy to describe the basis for relapse. This is Jean Cocteau in his biographical work, Opium, where he says, the dead drug leaves a ghost behind. At certain hours it haunts the night, hence the name for this talk, The Ghost and the Addict. What is the ghost that haunts the night for the addict? That is, lives on despite the recasting of the organism, the recasting caused by abstinence. You never seem to be free, as any former cigarette smoker might be able to attest. What is it that summons the ghost? Well, I'd suggest the ghost is summoned by the places, times, or situations in which the drug has been used in the past. More perniciously, in terms of treating the addict, these cues might be internal as well as external. That is, you might not see them, but if the individual took the drug when they were anxious, then if they're anxious again, they're going to feel a craving for the drug and display withdrawal symptoms because anxiety has been paired with the drug effect. If they get a small amount of the drug, like the alcoholic that gets a taste of alcohol, that might summon the ghost. Summoning the ghost is the same as eliciting the conditional response. Well, what are the applications of this research? I think we can much better understand and prevent drug overdoses by understanding that overdoses to a great extent when the drug is administered in the absence of the usual pre-drug cues, and in these circumstances the conditional responses that mediate tolerance are not expressed, and so overdose is a failure of expected tolerance to occur because you're no longer confronted with those cues. And the other application, it involves so-called cue exposure treatment of addiction. That is, if these cues play an important role in drug tolerance and drug withdrawal symptoms, then perhaps treatment should consist of somehow systematic exposure to these cues in a protected environment. But the therapist, and this is for the most part not done today, the therapist also has to consider the extinction of introceptive as well as extraceptive cues, not only the paraphernalia of drug addiction and the places where the drug is used, but also self-administration cues, drug onset cues, emotions, and images of drug use, and so on. Thank you very much.